Okay, so I'm mic'd up here all over the place because I like to walk around when I talk. I don't like to stand behind the podium. So hopefully everybody can hear me. Yes? Yeah. And someone said the slides are somewhere. Oh, they're there. Suppose I can't see them. I can see them. Okay. And do I have to do something to make them go forward? Oh, the clicker. You know, for an old guy like me, this advanced technology is really a drag. All right. Oh, that's how they work. Okay. So I was thinking this morning that I've been around the field long enough that when I joined the Society for Clinical Child and Adolescent Psychology, it wasn't the Society for Clinical Child and Adolescent Psychology. It was just Section 1 of Division 12 of APA. You know, it was the section on clinical child psychology. I mean, that's 30 years ago, believe it or not, or more when clinical child section actually started. So it's really been quite an evolution of the field over the past 30 years and very impressive. And I was really happy to hear that it was able to become its own division many years ago. So that's just tremendous. Little personal anecdote. Over 30 years ago, when I started in the child trauma field, and at that time I was at Western Psychiatric Institute and Clinic at the University of Pittsburgh School of Medicine in Pittsburgh, the chairman of the department called me in to have a little chat because I had only been there a couple of years. And he said, "Tony, you seem like a reasonably bright, capable guy, but you're only going to be here a year or two if you don't get out of this field." That's what he said. He said, "You know, we have lots of great researchers at Western Psych in the ADHD area, childhood anxiety, childhood depression. Why don't you sort of latch on with one of those folks and start doing something that's legitimate?" That's what he said. You really need to start doing something legitimate because the work that you're doing is a complete dead end and it's going nowhere. And I thought, oh, wow, I guess if I want to continue to do this work, I'm going to maybe not do it in Pittsburgh. But here it is, well over 30 years later, still in Pittsburgh, not at Western Psych anymore, but still doing the same work. And guess what? The field somewhere along the line actually became at least quasi-legitimate, which is pretty amazing, I think, because there was a time when it was not. So it's really great to be here and great that the field of childhood traumatic stress has become much more evidence-based over the last 20 years, and it's really wonderful to see really an array of clinical trials that have now been done supporting the efficacy of different interventions for kids exposed to traumatic life events. So I put this really basic, simple slide up here just to make sure that when we're talking about trauma, you know, we are talking about serious events in the lives of children and families. And the reason why I include it is because so often we hear people make comments like, "I'm so traumatized, you know, coming to work today was so hard, there was so much traffic on the way here," you know, that kind of thing, or "I had a late day at work," or "my boss yelled at me," or something like that. And, you know, the word trauma is used so often, and I want to make sure that when we're thinking about trauma, we are thinking about it, you know, within the parameters of the DSM-5 as a serious event witnessed, confronted, or experienced by a child or another individual. So at our Center for Traumatic Stress in Children and Adolescents, it's actually the 23rd anniversary of our center this past month. We see a variety of different types of trauma. And when we first started 23 years ago, the number one trauma type that was referred to our program was child sexual abuse. About 40% of all the kids over 20 years ago were referred for sexual abuse. Over 20 years later, it's still child sexual abuse. And that's despite some of the studies done by David Finkelhor and others around the country indicating that there might actually be a decline in overall rates of sexual abuse across the country. But the number one trauma type that we still see in our center is sexual abuse. The number two type, anybody want to guess the number two type? That's a great guess, but you're wrong. Domestic violence is number two. That's number two. And number three, anybody want to take a guess for number three? Want to try physical abuse again? Sorry. Anybody want to guess what's number three? Bullying? That's a good guess, but not. Traumatic losses. Yeah, traumatic losses are the number three referral type to our center. Kids who've experienced these losses in their families, among their age mates and so forth, through a variety of circumstances, but traumatic losses are the number three. But we do see a large array of different types of trauma at our center, and we don't see things like terrorism, although when we first became funded by SAMHSA to become part of the National Child Traumatic Stress Network. And you can see on the slide the National Child Traumatic Stress Network has now been in existence for 15 years, which has really been wonderful. But right after the initiation of the network was September 11th. So we became heavily involved in New York City related to the September 11th terrorist attacks. And of course, medical trauma as well. Now, in our center, and this is true among most programs around the country, if a youth is referred to us because of trauma exposure, almost always there are multiple types of trauma exposures. So in all of our studies, for example, if the index trauma was sexual abuse, most of these kids have typically been exposed to other trauma as well. Physical abuse, domestic violence, traumatic losses. In fact, in all of our studies, and this is true for most researchers around the country, the average number of traumas that kids have been exposed to as part of these research projects has been between 3 and 4. So when most kids are exposed to trauma, they tend to be multiply traumatized and not just one single index trauma type. So, it's interesting to me that a lot of folks don't know that about 2/3 of all American youth by the age of 16 have been exposed to at least one traumatic life event. 2/3. That's a huge number. If you think about it, 2/3 of American youth. About 25% of all girls have experienced sexual abuse or sexual assault by age 18. 1 out of 4. 1 out of 4. About 10 to 12% of all boys by the age of 18 have experienced sexual abuse or sexual assault. 25% of all children have grown up in families where there's been intimate partner violence. I mean, start adding up the numbers, right? Never mind all of the bullying that goes on at school and electronic bullying, traumatic losses, suicides, homicides, accidents, and so on and so forth. So we're talking about a large number of American children exposed to trauma. Now, there's good news and there's bad news. We do know, of course, that acute distress right after trauma exposure tends to be universal. Most kids exposed to trauma indeed are affected, and they have some level of distress. And of course, we also know that childhood exposure to trauma is a very significant risk factor for a host of psychiatric and other medical problems later in life, which I'll talk about in a few minutes. So exposure to trauma is a problem for kids. But there's some really good news. The good news is that most children exposed to trauma do not develop significant psychiatric problems. They do not. American children and children around the world, for that matter, are highly resilient. They have their own coping resources. They get support from their families and others. So most children do not develop serious psychiatric problems after trauma exposure. In fact, well, what is the percentage? Do you guys know? Anybody hazard a guess? 3%. 3%? Wow. Where do you live? I'd like to live there too. It's about 1/3 who develop significant emotional and behavioral symptoms after trauma exposure, but only on the order of 10 to 15% who actually develop PTSD, right? 10 to 15%. So you think about 2/3 of American children exposed to trauma, but only about 1/3 that develop significant symptoms, and only about 10 to 15% overall that develop PTSD. Okay? So that's the good news, right? American children are highly resilient. That's wonderful. But how about the bad news? The bad news is that for those kids who do develop PTSD and other trauma symptoms, even if they don't meet full criteria for PTSD in the DSM-5, because remember, the DSM-5 was based on field studies of adults, not children. And it's not easy for most kids to reach full criteria for PTSD. So the bad news is that for kids who develop significant PTSD or other trauma symptoms, they don't just get over it. They don't just spontaneously recover. In fact, these kids become at risk for a variety of other disorders during childhood, including depression, other anxiety disorders, drug and alcohol issues during adolescence, and a variety of additional psychiatric problems as adults. So that's the good news and the bad news. Most kids recover without significant psychiatric sequelae, but the ones who don't tend to have worsening of their problems over time, development of comorbidities, and significant risk for adult problems later in life. And I think this slide just highlights what I'm talking about. Are folks familiar with the ACEs studies? Yeah. Okay, so I won't spend a lot of time talking about it, other than to say that there's sort of this, I wouldn't call it sort of disagreement, but this differences in terminology has created some problems in the field. So you get people like myself that are thinking more of the traditional DSM-5 definition of trauma, right? Then we get folks talking about adverse child experiences, or ACEs, that overlap with trauma, but they're not one and the same, because from the ACEs studies, they include things like drug and alcohol problems in the family, psychiatric illness in the family, neglect, those kinds of things. So there's not sort of a total overlap between ACEs and trauma. And of course, the pediatricians now have their own sort of nomenclature. They're calling it toxic stress. So what is it? Toxic stress? Is it adverse child experiences? Is it childhood trauma? And to me, that's sort of just people spinning their wheels, because I think there's such great overlap among all of these categories that largely we're talking about one and the same phenomena, right? Because I've seen enough kids over time to know that even though significant drug and alcohol problems in a family and neglect may not be a trauma in the DSM-5, it is certainly traumatic to kids, right? I think most people would agree. And so, of course, the ACEs study has found that, kids who have a number of adverse experiences during childhood are at risk for a variety of adult conditions, and the presence of 4 or more exposures really increases the risk. 6 or more exposures results in a shortening of the lifespan by 20 years. So adverse child experiences, child trauma, toxic stress, call it what you will, they overlap, but they're not all one and the same. And people could probably have a debate all day here today on the differences among the terms, but call it what you will, these are bad for kids and they have long-term consequences unless they get help. Okay, so I think this slide is important because it reminds me of a phone call that I got yesterday from somebody in the community in Pittsburgh about a child who had recently disclosed that she was sexually abused, and she was like 7 or 8 years old. And she had disclosed just like 2 weeks ago, and the question, and she was exhibiting a variety of problems, including sleep difficulties, didn't want to go to school, some very mild sexual acting out. But she just disclosed a month ago. And one of the questions with kids exposed to trauma is, is this just a transient reaction to trauma that will dissipate after a month or two? And she won't be a child that develops longer-term psychiatric issues? Or is this just the early signs of PTSD and other problems she'll have down the road? The important issue here is that most kids in the aftermath of trauma exposure do develop transient distress. We should expect it, right? It's normal. I had another call earlier in the week from someone whose father had suicided, and this child is having difficulties a month or two later. Of course, what would we expect? But the question is, what does this mean for further down the road? So it's difficult to know whether these kids are going to develop PTSD, and transient symptoms and the nature of those transient symptoms in those first couple of months are not predictive of PTSD, one way or the other. So it's hard to know. So if you're trying to know based on the first couple of months after trauma exposure, it's going to be difficult to assess which kids later actually develop PTSD or other trauma-related issues. So lots of people think that the only diagnosis that we see after trauma exposure is PTSD, right? That's what we see often, for example, in our veterans who are returning from Afghanistan and Iraq. They often, about 25% of our soldiers have mental health issues after deployment, and a good percentage of those soldiers have PTSD. But among children who present after experiencing trauma, PTSD is a common diagnosis, but it's far from being the only one. So in addition to PTSD, depressive disorders are common, particularly after traumatic losses. Depressive disorders. Other anxiety disorders are common. And then comorbidity is the norm and not the exception. So we see lots of kids with PTSD and ADHD, kids with PTSD and ODD, substance use disorder, and so forth. What's interesting is when we're not asking about trauma exposure, sometimes kids wind up getting diagnosed with ADHD when really they might have PTSD. I'll give you an example of that. So several years ago, my nephew was deployed for the second time to Iraq. And he's got, at that time, a 7-year-old son at home in the second grade. And he was deployed in the summer. And his son knew a little bit about where his father was going, my nephew, and had some worries about that, but my nephew and my nephew's wife were reassuring of their son. So anyway, he goes off to Iraq, and in the early fall of that school year, my nephew's son began to have difficulties concentrating at school. He was struggling doing his schoolwork. His mom reported that he wasn't sleeping well at night. And he didn't like to talk about his dad because he was worried that maybe something bad would happen to his dad. So he didn't talk about his dad, didn't want to talk about him with his mom. So my nephew's wife took their son to the pediatrician, and he heard, let's see, difficulties concentrating, inattentive, and so on and so forth, and started him on a trial of Ritalin. Never asked about the family circumstances, never asked that his father, my nephew, was deployed to Iraq, never even considered that. So automatically diagnosed with ADHD. And historically, that's been one of the greatest issues in regard to the trauma field, and that is that we haven't asked about trauma exposure. Why do you think we haven't? Anybody, any thoughts? Why do you think we haven't asked about trauma exposure? Yeah, we don't want to know. What happens if they say yes? What happens if they in fact tell us that they experienced some kind of trauma in their life? It's like, whoa, sorry I asked that, right? Yeah, so we often, until the last decade or so, in clinical settings, haven't asked about trauma exposure. In fact, instead, we inquire about a youngster's behavioral and emotional difficulties, which are typically the presenting complaints, but we don't ask about trauma exposure. We ask about family background, social history, so on and so forth, but historically, we haven't asked about trauma exposure. Well, if you don't ask about trauma exposure, there's no way you're going to understand the trauma-related disorders that these kids might present with. So, you know, kids may have PTSD, not ADHD, or they may have ADHD, not PTSD, or guess what? They might have both. In fact, some of the most challenging kids to work with who have trauma exposure and PTSD are those little 4- and 5-year-olds that also have ADHD. And trying to get them to focus on trauma treatment is a real challenge. We also know that up to about 20% of all kids, particularly adolescents, who present with trauma exposure may have psychotic symptoms. And again, the diagnosis here can be challenging. Might this be early onset schizophrenia, right? Or is this related to their trauma exposure? I saw a teenage girl several years ago who had been sexually abused or assaulted by 3 different people over the course of her life. And when she presented to our clinic, she was having command hallucinations of the type that were telling her, you're worthless, you need to kill yourself. But as it all turned out, as she went through trauma treatment, and she was stabilized, I should add, on some antipsychotic medication, but as she went through the trauma treatment, it was clear that those psychotic symptoms were related to her trauma exposures. By the end of trauma treatment, she didn't any longer need any antipsychotic medication. But again, if you hadn't asked about trauma exposures and background, you might just think this was a young lady developing early onset schizophrenia. So obviously the issue here is all about asking youth about trauma exposure. Of course, in many circles these days, we're talking a lot about complex trauma. And this, usually, we're referring to kids who've been exposed to many traumas early in their lives, often in their family of origin, often traumas that have resulted in these kids being displaced from their early homes. And then we're also talking about their clinical presentation as well, because PTSD is often not sufficient to describe how these kids are doing. So in addition to PTSD, they also typically have severe affective dysregulation, interpersonal difficulties, self-esteem issues, shame, self-blame, and so forth. So we were talking a lot about kids these days, particularly youth in foster care, kids in the residential treatment system, in the juvenile justice system, and so forth, often having experienced complex trauma. And you know, what are the treatments that are necessary to work with this particularly vulnerable population? Okay. So the sad state of affairs is that the majority of traumatized children are never identified, right? So I mentioned the statistic earlier that 25% of all girls have experienced a sexual assault or a sexual abuse by age 18. Now, if all of those girls, and 10 to 12% of all boys, if all of those kids were presenting at mental health programs around the country because of this trauma exposure, our mental health programs would be inundated, right, with youth who have this kind of trauma experience. But the truth of the matter is that many of these kids are never identified, including because they've never disclosed. I mean, how many kids go throughout their entire childhood, adolescence, and early adulthood, and they've never, ever disclosed their experience? I remember one grandmother in particular, any number of years ago, whose 5-year-old granddaughter, and she was the caretaker for this child, was presenting in our clinic, and she had been sexually abused. And this grandmother, I think, was about 50 years old, okay? So I was meeting with her at the end of the evaluation, and she was quite tearful. And I said to her, trying to be empathic, I said, I know this is hard to hear about the effects of the sexual abuse on your granddaughter, but I'm hopeful that she's going to be okay. We've got treatment that can be effective for her, and so forth. But this grandmother continued to cry. And I asked her what was wrong, and she said, I need to tell you that I was sexually abused when I was a young child. And that was like over 40 years ago. And the first person I'm ever telling is you right now, right? 40 years later. So many, many kids who have experienced trauma are not identified. An even smaller number are ever evaluated and receive treatment, right? And for those who do receive treatment, the majority do not receive evidence-based treatments. So what would you guess are the most commonly used treatments around the country for kids exposed to trauma? Play therapy. That's one of the two. That's exactly right. And what's the other? TF-CBT? It's a great guess, and I wish you were right, but you're not. It's non-directive therapy. The two most common therapies are play therapy and non-directive therapy. Even in 2017, we did a survey of therapists around the country a few years ago, and those are still the most popularly used treatments for kids exposed to trauma. Non-directive treatments and play therapies. Despite the fact that neither has been studied extensively like many other treatments have. So play therapy and non-directive therapy. So let me tell you something about non-directive therapy for kids exposed to trauma. So in our studies related to TF-CBT, one of the comparison treatments often was non-directive or client-centered therapy, right? And in the client-centered or non-directive therapy, kids had the opportunity basically to talk about whatever they wanted to. And when they would come in, they would talk about school, or they would talk about their friends or things going on in their family, all of that kind of stuff. How often did they bring up the trauma? Almost never. Almost never. As part of the treatment outcome studies that we conducted, in order to encourage these kids in the non-directive treatment forward a little bit, at every third session we prompted them. These kids in the non-directive treatment. We prompted them by starting a treatment session with something along the lines of, have you been thinking about, whatever the index trauma was, right? Have you been thinking about when you were sexually abused by your father? No, right? And this is despite the fact that they knew they were referred to the project because of that index trauma. So even when we prompted kids who were getting non-directive or client-centered therapy, what we learned in all of our studies is that they never, ever talked about what happened. Never talked about what happened. And now, does that mean the non-directive therapies were not effective to some degree? They were. But they never spoke about their trauma. And my experience has been that when kids don't speak about their trauma, and therapists who do non-directive techniques don't speak to kids about their trauma, at the end of 6 months, these kids were referred for non-directive trauma therapy. Never once have they spoken about their trauma. And we've commonly had that experience. So let me tell you a quick anecdote that one of the developers of TF-CBT, Esther Demlinger, shares this anecdote. This is quite a few years ago, but it's as relevant today as it was way back when. So there was this boy that was referred to her. He was about 10 years old, who had been sexually abused. And he had seen another therapist in New Jersey for over a year. And the other therapist referred the child to Esther because she wasn't making great progress with him. So when Esther saw him for the first time, she asked him, she said, I know you've seen this other therapist for a long time. How often did you talk about the sexual abuse? And the little boy said, oh, we never talked about it. And Esther said to him, wow, you saw her over a year. You never talked about it? Not even one time? And the little boy said, no, not even one time. And Esther said, well, why not? And the little boy said, well, my therapist wasn't ready. So if you have kids who aren't ready, and you have the most common form of therapy out there for kids exposed to trauma, non-directive treatment, from therapists who are not talking about the child's experience, what do you get? You get kind of a collusion between the kids and the therapist to never really address what went on. Okay. So it is true, our center in Pittsburgh is a specialized center, so we get most of our referrals of kids that we know have been exposed to trauma. But that's not true for most kids exposed to trauma. Most of them are referred to general mental health programs. Kids present with behavioral and emotional difficulties. They're often not asked about their trauma history. And if we wind up treating just their behavioral problems, it may not be effective because we never got near the trauma exposure, which may be the root of the problem. Interestingly, David Brent, a renowned child and adolescent depression researcher, recently has had some findings in their projects doing really state-of-the-art interventions for adolescents exposed to, or adolescents with depression, that they've found that one of the moderating factors with regard to the success of depression interventions, which have included both medication and typically CBT, has been trauma background. That if these kids didn't get any kind of intervention related to their trauma background, their outcomes in their depression interventions were lower. So there's something going on there in regard to when we're not addressing kids' trauma in their backgrounds. Outcomes can become worse over time and may result in kids having higher levels of care, like group homes, residential programs, and so forth. Okay, so I've sort of been touching on this throughout what I've been talking about so far. Most child therapists, how many people here are child therapists or aspiring child therapists? Okay, so most of you. So one of the great things about child therapists is they are some of the, and I won't include myself for the moment, but are some of the most loving, kind, compassionate people I have ever known. Really, it's a great testament to the big hearts that child therapists have. But because of that, sometimes we child therapists are afraid we're going to re-traumatize kids. So if they're not ready to talk about what happened, we're going to re-traumatize them. And we're going to hurt them. If our job is to help these kids get better and we re-traumatize them, oh my God, I've done just the opposite of what I'm trying to do. So many therapists are afraid that by actually bringing it up, and the favorite line I hear so often is, before she's ready. Well, if you wait until she's ready, you're going to have a lifetime of waiting because she's not ever going to be fully ready to talk about it, because that's what trauma exposure is all about, right? Avoidance. Kids don't typically cheerily come into our office and say, "Oh, Dr. Tony, I can't wait to talk about when I was assaulted." That doesn't happen. So we're afraid to re-traumatize them, but the truth is, if we don't talk to kids about their experience, it's still living inside of them. It's living in their brain, it's living in their body, it's living in their mind. And it's affecting them in a negative way and putting those kids at risk for long-term, significant psychiatric and other sequelae. So, yes, we don't want to hurt kids. We don't want to be coercive about our interventions in any kind of way. But on the other hand, we do need to help them process what happened. Secondly, vicarious traumatization. It's hard to hear what these kids have to talk about. It's not easy to hear kids talk about their experiences of sexual abuse and physical abuse, domestic violence, traumatic losses, and so forth. It's hard to hear, for sure. And then, not so much recently, but for a long time, we used to hear therapists in different programs around the country make comments like, well, our clients are different. They're not like the client you have in Pittsburgh, who are able to talk about their trauma experiences. So our clients are different. They really can't participate in a therapy where they actually begin to address and deal with their trauma. So that, I would say we don't hear that one so much anymore, but I'll tell you what, we hear the other two all the time. And probably this one the most. We're afraid we're going to re-traumatize kids. But again, as I said a few minutes ago, we have to remember that what happened to them is inside of them. And it's up to us to help them deal with it and process it, right? And so we've got to be able to deal with this, right, the vicarious traumatization, if we're going to be able to go forward and help them deal with their own experience. So one of the things I've found interesting over the years in the trauma field is that, again, because we have such big-hearted, compassionate, kind child therapists, is that, as kids have experienced some type of trauma, often therapists just want to jump in and do therapy. But I think we all know that assessment is just absolutely critical with this population of kids, just like with anyone else who might get psychotherapy or any other kind of intervention. First and foremost, of course, we need to understand, has there been trauma exposure? And what type, right? Trauma exposure and what type? And secondly, are there trauma symptoms? What I hear a lot around the country is a child's been sexually abused, witnessed domestic violence, and never assessed for trauma symptoms. So we're just automatically assuming that if they've had trauma exposure, they've got trauma symptoms. But remember, as I said earlier, 2/3 of American kids exposed to trauma don't have significant psychiatric symptoms. So if we treated everybody just with trauma exposure, we've been treating a lot of kids who don't need treatment. So we have to assess for trauma symptoms as well. We have to decide what type of trauma treatment is going to be most appropriate. Now, in terms of trauma exposure, there are several screening tools out there. There's the Traumatic Events Screening Inventory for Children, or TESI-C, developed by Julian Ford and his colleagues at the University of Connecticut. It's a good measure. We've used it any number of times in our studies. And then there's also, in the UCLA PTSD Reaction Index for the DSM-5, the first section of the scale, which also includes questions about the child's experience, during the trauma, and also questions regarding PTSD symptoms. But the first section of the scale does ask about exposure to a variety of traumatic events. Now, one of the really interesting things, I don't know if you guys have experienced this over the years, is that if you ask kids about trauma exposure in sort of like an interview format, it's more likely that kids will deny it in an interview format than they will on self-report in a paper and pencil measure. So things that they won't tell you out loud in an interview, they may well actually check the box on something like the TESE or the UCLA scale. So if obviously you can't use these paper and pencil measures for really young kids, but for kids 7, 8 years of age or older, if you have the opportunity for them to share their experience related to trauma exposure in self-report through a paper and pencil measure, that would be, that usually gets kids to talk more about things that have happened. We're actually working right now on sort of a game app for PTSD assessment. We're right sort of in the final stages of developing it, where it's sort of a game-like format where kids can identify exposure and symptoms. But I wish we were finished and I could share it with you today, but we're not quite done. Okay, in terms of trauma symptoms, there are several out there. The UCLA scale that I just mentioned. The UCLA scale is a great scale for several reasons. One, there's a version for kids 7 to 12. There's an adolescent version for kids 12 to 17. And then there's a parental version as well. So that really makes it a great measure. The downside of the UCLA scale is it's no longer in the public domain, and you have to have a licensing agreement with UCLA in order to use it. And in every administration of the scale costs you $1. So if you're a program that uses these kinds of scales with great frequency, you have to have an investment of some money to use the UCLA scale. So a lot of programs around the country are now using the Child PTSD Symptom Scale for the DSM-5. This is Edna Foa's scale, and it is in the public domain. And basically, there's two areas of the CPSS-5. One, there are 20 symptom questions related to PTSD, and then there are 7 questions related to functional impairment. So the fact that they have those functional impairment questions is a great asset of this scale. And I'll also mention the trauma symptom checklist for children developed by John Briere out at USC, and the Young Child PTSD checklist, which is completed by parents for preschool and young primary grade children. Okay. So let me just move on here and talk a little bit about treatment. Well, just a word before I get to psychosocial treatments. So you should know, and maybe you already know, that there is no medication that is FDA approved to treat children and adolescents for PTSD. Folks know that? No medication. Despite the fact that kids are given medication all the time for PTSD, there is no FDA approved medication. There have been very few clinical trials of medication for kids with PTSD. There's only been 1 or 2 randomized trials, and the randomized trials have not demonstrated the efficacy of medications. And in fact, if you look at the practice parameters for PTSD of the American Academy of Child and Adolescent Psychiatry, medication is not a frontline intervention, even by the Academy of Child and Adolescent Psychiatrists. Medication is not a frontline intervention. So evidence-based treatments, what they're not meant to be rigid, lockstep, inflexible, certainly not meant to be cookbooks, but that's what everybody thinks. When I do TF-CBT trainings, the first thing that everybody's worried about, they're worried about whether we're talking about a cookbook or not, and people don't like cookbooks. So how are EBTs similar to the usual treatments that therapists provide for kids exposed to trauma? Well, certainly the therapeutic relationship is important, right, and is central. If you don't have a strong therapeutic alliance, TF-CBT or other evidence-based treatments are not going to be effective. In one of the randomized trials that was done of TF-CBT in Norway recently, they found that the strength of the therapeutic alliance midway in TF-CBT was predictive of better outcomes. So the stronger the therapeutic alliance, the better the outcomes for PTSD and other problems. So the relationship is important in evidence-based treatments for kids exposed to trauma. Certainly, therapists' creativity and judgment are valued and critical to success. It's important that therapists understand that even though there's fidelity to the treatment model, there needs to be flexibility in its implementation. And of course, cultural, religious, developmental, and other family values are respected, and that's a big part of the work. Okay. So let me talk a little bit about some of the evidence-based treatments out there. Unlike the adult trauma field, where there basically are 3 widely used psychosocial interventions for adults with PTSD. And those are, Edna Foa's prolonged exposure treatment, right? Patty Resick's cognitive processing therapy. And then thirdly, eye movement desensitization and reprocessing, or EMDR. Those are the 3 most widely used trauma treatments for adults. In the VA system across the country, prolonged exposure and cognitive processing therapy are being widely disseminated, okay? So there are these 3 treatments that are sort of defining the adult trauma intervention field. Well, in the child trauma field, and I think partly because of the National Child Traumatic Stress Network, we've had this extraordinary proliferation of interventions for kids exposed to trauma. And one of the challenges has been, how do we know which of these treatments are sort of evidence-based and which ones aren't? And I think it's one of the sort of ongoing discussions that we're having in the NCTSN in regard to which ones are evidence-based and which ones show promise but really don't have an evidence base at this point. So I want to mention several that at least have some evidence base at this point. And that includes EMDR, eye movement desensitization and reprocessing. EMDR is wildly popular and widely used throughout Europe, okay? I mean, CBT is just beginning to get some kind of foothold in Europe, but EMDR has been used for quite a long time, and it is the most frequently used treatment for both kids and adults in Europe. Now, in the US, EMDR is used, which I think much less frequency, despite the fact that there is good empirical support for EMDR in adult non-combat trauma survivors. However, some of the research that does exist with regard to EMDR does challenge the whole notion of whether the bilateral stimulation, whether it be the lights, the eye movements with the lights or the sounds, how critical that is to the outcomes. And some research suggests that it's just the actual trauma processing that's critical and not the bilateral stimulation. Not too much research in regard to EMDR with kids. However, there was one study that I was part of in the Netherlands comparing EMDR versus TF-CBT. And in that one study that was published a couple of years ago, it was actually Julia Deal's dissertation. She found that in regard to PTSD symptoms, that EMDR and TF-CBT were equivalent in outcomes. One thing she thought would be true would be that since most people believe that EMDR can be implemented in a much shorter period of time, that the number of sessions for EMDR versus TF-CBT would be many fewer. But as it turned out, the number of sessions was equivalent across the treatments. And the other significant finding from that study was that TF-CBT was much more effective for comorbid behavioral problems, anxiety, and depression than was EMDR. So equally effective for PTSD, but TF-CBT much more effective for the other comorbid issues. Child-parent psychotherapy developed by Alicia Lieberman and her colleagues out in San Francisco. You know, it's basically a dyadic form of psychotherapy for young children and their caretakers with a focus on enhancing child-parent attachment, promoting safety and trust. And at this point, Alicia and her group have one clinical trial demonstrating the efficacy of CPP with young children exposed to domestic violence. They've also done a lot of work with CPP for kids who've had traumatic losses. Alternatives for families, a cognitive behavioral therapy, AF-CBT. This is a model developed by David Kolko and Alyssa Brown, largely focusing on families where there's been either coercive physical punishment, poor conflict resolution techniques, physical abuse, those kinds of things. And the focus is on skill building for the child and helping parents learn more positive discipline, limit-setting strategies. Two RCTs supporting its efficacy. And there you see the website, afcbt.org. I think that AF-CBT is a particularly good model where the parents are integrally involved in the therapy, even if they've been the perpetrator of physical abuse, to learn other types of limit-setting strategies for their children. Trauma Affect Regulation, Guide for Education and Therapy, or TARGET for short, a model developed by Julian Ford and his colleagues in Connecticut. It was originally designed as a therapy for adults, focuses largely on affective regulation, coping skills, not so much on trauma processing. It's now been applied with children and youth and with complex trauma histories, kids in foster care, residential settings, juvenile justice settings, and there's one RCT supporting the efficacy of Target with adolescent girls in outpatient juvenile justice settings. You know, I'm sure all of you are familiar with PCIT and what it is. You know, Anthony Urquiza out in Sacramento did a study, though, where they demonstrated that young children and their parents participating in PCIT, one sort of incidental finding was that these kids had also been exposed to trauma, and there was a reduction in trauma symptoms in response to PCIT, even though the PCIT per se wasn't focused on trauma. And I think it's just a good illustration that when parents become more attuned to their children, more effective in limit setting, the behavioral problems associated with trauma exposure will clear up. And then trauma systems therapy, a model developed by Glenn Sachs and his colleagues in New York City. It's more of a systems approach, not so much a therapeutic model, that it incorporates the various systems involved in the child's life, child protective services, school, juvenile justice, and so forth. And some promising strategies without any research support at this point. So let me just take a few minutes to talk about TF-CBT. I am going to talk about TF-CBT a lot this afternoon. So TF-CBT is really a hybrid treatment. We called it trauma-focused cognitive behavioral therapy. We came really close to calling it trauma-focused components-based therapy. But there were 3 developers of TF-CBT, Judy, Esther, and myself. And whenever we had a decision to make, they always won. So it incorporates trauma-sensitive interventions, CBT principles, attachment theory, and so on and so forth that you can see on the slide. We've been really fortunate. There have now been 20 randomized clinical trials conducted around the world supporting the efficacy of TF-CBT. 9 of those trials have been done by Judy and Esther and myself, but there's been many more trials now conducted around the country and around the world. So there have been 2 randomized trials in the Democratic Republic of Congo, one study with sex-trafficked girls, and a second study with boy soldiers who were part of the civil war in Congo. And on the average, for both of these studies, either with the sex-trafficked girls or with the boy soldiers, they had been exposed to, on the average, of 10 or more trauma in their lives. So these were complexly traumatized kids in both of these studies. And the outcomes were wonderful. They received TF-CBT on a group basis, not individual therapy, with the exception of the trauma narrative portion. And the results were really extraordinary in terms of PTSD and other outcomes for these kids in Congo. A study by Laura Murray in Zambia, similar in many ways to the Congo, except the major difference was that the therapists in Laura's study were lay therapists. They were not mental health clinicians. They don't have a large workforce in Zambia of trained mental health clinicians. So Laura spent hours and hours and hours, and then when she was back in the US, Skyping to do supervision with the therapists in Zambia. Similar to the studies in Congo, these kids have been exposed to 7, 8, or 9 or more trauma, and the size of her outcomes were actually greater than what we found in our studies here in the US. The effect sizes were significantly greater. And it was a remarkable study in that it showed that you could use lay therapists who are well-trained, but most importantly, with kids with extensive trauma backgrounds, many of whom were still being exposed to ongoing trauma, still get really great outcomes from that particular project. Tina Jensen and her group have done an amazing study in Norway with TF-CBT with great outcomes. I mentioned the one in the Netherlands, and then just a randomized clinical trial that was recently completed in Germany, all supporting the efficacy of TF-CBT. There are 2 other studies I'll mention that aren't on the slides. One by a group at the University of Delaware that's been sort of looking session by session of TF-CBT to see whether early sessions predict certain kinds of outcomes. And what they found in that study was that in those early sessions, like 1 to 6, when parents are more supportive of their kids, less avoidant of talking about the trauma, and better able to process the trauma, that the kids have better outcomes at the end. And it really underscores the importance of including caretakers in the treatment, because when they're processing what happened, they're doing better. The kids are doing better. And then another study done by Alyssa Brown and her group in New York, which demonstrated that for kids that were not nearly as stabilized entering into the trauma narration portion of TF-CBT as we would hope they could be, that many of these kids achieved much greater stabilization once they did the trauma narration portion of the model. And I think her results underscore that kids aren't always perfectly stabilized before they start a trauma narrative. And often the trauma narrative will sort of help them move further along in that regard. And some of the outcomes, as you see listed on the slides, with a variety of different traumas, a variety of great outcomes. But the outcomes that I'm most satisfied with is that the parents get better too. And this isn't their own individual therapy. This is therapy for their kids, but the parents are participating in collateral sessions. We have improved parental distress, improved parental PTSD, significantly greater parental support, significant improvements in parental depression. So we can tell parents when they start TF-CBT, we believe that your child will get better. And the outcomes suggest that the children get better about 85% of the time, significantly better. But the parents get better as well. Just the practice components of the model, which I'm going to talk a lot more about this afternoon. The phases of TF-CBT treatment, which I'll talk about later. Stabilization components, the trauma narration and processing, and then the integration phase. I do want to mention just a word about our TF-CBT web-based course. It's been around for 11 years. It's on the platform at the Medical University of South Carolina. As of Monday, I got this from Ben Saunders, 312,000 people from around the world have registered for TF-CBT Web, and over 170,000 have completed the full course. And even as of Monday, the average rate of new learners is 123 a day, which is really pretty cool. We are in the process of revising TF-CBT Web. The 2.0 version will be out late spring of 2017. A couple of other web-based resources as well. And this is just a little bit more about TF-CBT Web. This is the home page, what you'd see if you went to the web-based course. And therapists do get 10 free CE credits if they complete the course. So it's free, I might add as well. Okay, so I'm going to stop there. And I do have a lot more to say about TF-CBT specifically this afternoon. But happy to entertain any questions, comments, challenges, put-downs, or anything else you care to bring up. Yeah. Thank you. Yes, sir.
Yes, I have more of a comment. In my practice as a clinical social worker in our schools, I find trauma-focused CBT very effective in encouraging self-efficacy and emotional regulation in my students. So, and this, of course, is not sabotaging, without sabotaging the importance of the therapeutic alliance, the relationship that we have to build with our clients, the emotional regulation that we want to encourage our students to learn. I just wanted to say that. And with the course, that was actually my second question, but you answered it, so.
Okay. So we were taping your comments, and we'll put them on our website now. I'm kidding you. Thank you for that. You know, I think there are therapists implementing TF-CBT in the schools around the country. There are some challenges, as I'm sure you know, in that regard, in terms of just the timing during the day, when kids would have therapy sessions, plus how to get parents involved because they're not accompanying the child to school. But it is an important setting in which we are implementing TF-CBT, so thanks for your comment. Yes, sir.
Hi. Susan Nell has modified CBT for play, cognitive behavior play therapy. Can you say a word or two about the modification of trauma-focused cognitive behavior play therapy? I know the limitations of play therapy in the empirical literature, but for those play therapists out there who are interested in utilizing trauma-focus with a play base.
No, that's a great question. So I'll make two comments on it. The first thing is that, of course, TF-CBT is an evidence-based treatment for kids ages 3 to 18. But with young children, 3, 4, 5, 6, or 7, you're not going to implement the model with traditional verbal psychotherapy. We've got to incorporate a variety of play strategies that would be used to implement the TF-CBT components, whether it be psychoeducation or relaxation, helping kids learn to express and identify their feelings. You've got to do play strategies to make those things happen. And so a big focus of TF-CBT with young kids is the use of play strategies to implement the components. So that's the first comment. So it's a very play-oriented model for young kids. It needs to be. You can't sit across from a kid and just talk about what happened when they're 5 or 6. On the other hand, Brian Allen, who's at Penn State, completed a study recently looking at therapists who were doing TF-CBT and some therapists who were doing traditional play therapy and some therapists that were sort of incorporating traditional play therapy, not the way I was just describing it, but just more non-directive play sort of interspersed with the other TF-CBT components. And what Brian found in his study was that TF-CBT was less effective when there was less fidelity to the model. So it's one thing to incorporate play into the model to be able to deliver the components. It's another thing to just sort of do TF-CBT one session, non-directed play therapy the next, and so forth. And Brian found in his study that the outcomes were not as good when therapists were kind of going back and forth. That's a great question. Thank you. Anybody else? Yes, please.
If a community experienced a trauma like hurricane or a shooting or something like that, how long a period would you recommend to administer, let's say, to a school the inventory?
Yeah.
See who
Yeah, that's a great question. So if a community experiences a trauma, how long should we wait? Well, you know, we had this happen in Pittsburgh 2 years ago. We had a student at one of our local schools show up at school right at the early morning bell with 2 butcher knives from home, randomly went down one of the hallways in the school, stabbing students, often in the back, some turned around, in the chest. 20 students were stabbed, 2 adults were stabbed. Thank goodness nobody died. Several students almost died, but tremendous surgical teams saved their lives. But anyway, to your point, right from the start, we went in there and we did education with teachers, with students, with families about the experience that these kids went through, the likelihood that most students would have, as I talked about in one of the slides, transient stress, sleep problems, and of course, don't want to go to school, because that's where the event occurred, and that was expected. And I think it was helpful to the teachers and the families to know that their kids would have difficulties for the next several weeks. So they weren't worried that, oh my gosh, my child has a serious psychiatric problem. We were trying to help them understand this was a typical reaction to a traumatic event. And then it was this happened in April, okay? And believe it or not, the referrals for kids who really needed extra help didn't start till the fall. So what happened is that the kids got through the school year, and then the summer intervened, right? And then at the beginning of the school year, then the kids who were really having a rough time. That was true in New York City, I would add, after September 11th. Of course, it happened in September, right, of 2001. Most of the referrals from the school systems didn't start happening until March or April of the following year. So you can't really, and that was true, I also would add, for Hurricane Katrina in New Orleans. So you can't really identify the kids are truly going to be in need right away, but I think it's good to go in there and do education and also identify kids who right off the bat are struggling for some reason. Kids who might be suicidal, kids who might be psychotic, kids who need services right then, even though they may not develop PTSD. So that's what we did in that school system. So I think you can go in, do education, provide information, talk to parents and families about any really serious concerns that would warrant an immediate referral, but then what to look out for it in a couple of months in regard to kids that may need longer-term help. Yes?
I'm from New Orleans, so.
Okay. Yeah.
So I was asking, in terms of that, and then recently we had a community go through a tornado.
Yes.
So if we went in and did the educational part of it, and then you said, like, it didn't show up until the fall and fall, would there be a period of time where you would have the funding to administer an inventory to the group to identify them?
Yeah. So her question now is that if you do wait for a while, should we do things like kind of mass screening of kids for PTSD? And I think potentially it's a good idea, but on the other hand, if you do a mass screening and you find about a third of the kids who have PTSD, it's like, what are you going to do? I mean, do you have the resources, available staff, and so forth to provide services for those kids if indeed you go in and do that kind of mass screening? So I think there's a lot of value to what you're describing, but on the other hand, if we do a mass screening, what can we offer those kids and families?
I have a question.
Where are you?
I'm over here.
Oh, okay.
So we do TF-CBT at our clinic, and we find sometimes that a caseworker will call up and say, we have this child that there's never been a disclosure. We have no necessary evidence of any kind of trauma or abuse, but there's no way this kid could have so many problems without there being a trauma. Can you just do the trauma-focused therapy on them, and maybe you'll uncover something in the narrative? And I know how we respond. I'm just interested to hear how you
Well, tell me
respond to that.
Tell me how you respond.
That's not the purpose of the trauma narrative. It's not
Thank
to
you.
uncover
Thank you.
memories.
Thank you. The categorical answer is they would not get trauma treatment unless they've had trauma exposure and trauma symptoms. And what you're describing happens so often around the country. A kid has all these problems, but even a child with sexualized behaviors may not have a history of sexual abuse. I mean, all of the wonderful research that's been done in Oklahoma with kids with sexualized behavior problems, about 50% don't have a history of sexual abuse. So we automatically assume they have sexual behaviors, therefore they have a history of sexual abuse. Well, maybe not. So I couldn't agree with you more. TF-CBT is not a forensic intervention to uncover abuse or other trauma. It's an intervention to help kids heal when they've been exposed to trauma. And I'm glad you mentioned the trauma narrative. We've actually created something called the trauma narrative disclaimer that we give to outside parties, Child Protective Services, lawyers, and others, to help them understand what a trauma narrative is and what it's not. And what it is not is a factual, objective version of the facts. What it is a child's subjective perception. So I really appreciate that you guys are handling that the way you are. Thank you.
And they don't like it when we say that. So I wanted to see if you had any other magic, or at least I can say,
Yeah.
this is what they say in
Of course they don't like it, because they want us to substantiate their abuse concerns, right? Hey, yes, please.
I just want to make a comment. I'm glad that you guys came up with that. So I'm in private practice now, but I was at Christie House for 10 years.
Ah,
And I had a situation where I had to testify in court, and the trauma narrative was passed around the jury box. And I was
Oh, my God.
furious. But the thing is that mom had requested the records, and she had kept it.
yeah,
And she gave it to her attorney, who then has to turn it over
of course.
to the other attorneys.
So she's describing a situation where the courts got a hold of the trauma narrative and it was used as evidence in a case. And that's sort of one of the things that I wake up at night about with nightmares.
I was assured that the child had no knowledge,
Yeah.
but I
Yeah.
just was so
Yeah.
fearful of that.
The only other comment I'd make in regard to your comment is that these kids tell us about what's happened in their lives because of knowing that it's confidential. And all of a sudden it's showing up in court. It is such a betrayal. Hey, listen, I've got to stop because the other presenter is going to be coming up here soon. But thanks so much for your time and your attention.